Hi, my name is Dr. Paul Christo of the Johns Hopkins Hospital. I'm also chairing the Pain Care for Primary Care event and conference here in Orlando, Florida. I have three topics that I'd like you to consider. One is when to send patients for epidural steroid injections. If you have a patient who has a herniated disc, for example, in the lumbar spine, and it's causing back and shooting leg pain that otherwise is not being treated with medications, or if the patient has become disabled, can't work, consider them for an epidural steroid injection in the lumbar spine, or even in the cervical spine for shooting arm pain in those instances. The evidence is strong that it can be helpful acutely for patients who have radicular pain, especially in the lumbar spine. So consider that in patients who have shooting leg pain or shooting arm pain from disc herniations or even from spinal canal stenosis. Secondly, if patients have pain in the low back or in the neck that's facet joint driven, consider sending patients to us for diagnostic facet joint blocks in those areas. The evidence is strong that if patients respond to those local anesthetic injections in those particular regions of the body, that they will benefit from denervation procedures of the facet joints. For patients who have pain that's in the low back, specifically along lumbar level 5 or below, say in the buttock, consider sacroiliac joint as a pathology. Send patients to us for diagnostic intra-articular sacroiliac joint injections in those circumstances. We have evidence that's fair that if we perform a cooled radiofrequency procedure of the nerves that supply the sacroiliac joint, if they respond to diagnostic blocks, that they can get 3 months, even 12 months of significant pain relief. And finally, if you have patients with failed back surgery syndrome, that is, they have persistent back pain and shooting leg pain after having had surgery, consider sending those patients to us for a trial of spinal cord stimulation. Spinal cord stimulation in multiple studies has shown to be effective in patients who have failed back surgery syndrome, effective in terms of pain relief and functional improvement. We perform a trial first that lasts about 6 days. If patients respond, that is, they get significant relief and have changes in quality of life, well, then we offer the implantation. I think this is a serious consideration in not only patients who have failed back surgery syndrome, but other specific pain conditions as well. I hope you found this information helpful, and thank you for joining me in the Journal of Family Practice for this 3-in-3 presentation.